First of all, I would like to thank Dr. Mesbahur Rahman. It is our honor and pleasure to introduce him. Dr. Mesbahur Rahman is a consultant gastroenterologist, and he worked in Swansea University Health Board in United Kingdom. He has a tremendous interest to help in gastroenterology sector in Bangladesh, and for the last many years, he is doing it very closely with all the gastroenterologists in Bangladesh. And it is our pleasure to bring him here, and also he's very kind that he participated in our effort of Planetary Health Alliance. As you know, our goal is to not a big program. Our goal is to do a small program with a very small, interesting segments of young physician. Our goal is to make association, close association with Bangladesh Gastroenterology Society, and very soon we'll have a formal meeting with them. I can see one of the legend of Bangladesh Gastroenterology Society and the whole gastroenterology program in Bangladesh. Professor Mahmoud Hassan is here. Dr. Ghulam Kibriya is here. And I see a lot of young physicians who are here. First of all, I would like to thank you all. Today's topics is a very important topics for the gastroenterology perspective, especially obscure GI bleeding, diagnostic approach, and management. It is true that in Bangladesh, we might not have all the tools we are using here for a long time, both in UK and USA, or Australia and New Zealand, where our faculties are talking from. But I'm very sure that in Bangladesh, all of you are about it. We do have a limitation today, and our sincere apology for that we couldn't able to do the way Dr. Mesbah wanted to do it today, showing some videos. We have some problem with the interfacing the Zoom with the video, as well as an advanced response system where he could have present some cases and see the response from the audience. But we are trying to improve it, and hopefully in our next programs, we'll overcome those problems. Again, I would not take much time. Once again, I'm sorry for delaying our program, but I would like to, again, thanks Dr. Mesbahur Rahman, and I would kindly request him to start today's lecture.
Thank you, Dr. Atikurjaman. Thank you, and welcome everyone. I feel very honored to be here. So what I was saying is that on an average, the patient requires blood transfusion, and before we come to diagnosis or treatment, they, on an average, can have as high as 40 units of blood transfusion, and on the lower side, it would be about 20 units of blood. So general rule for investigating these patients, or that what we are looking for is the patient, if the patient is very young, it would be, if there is overt bleeding, it would be Meckel's diverticulum. Otherwise, it would be a Dilofoy lesion or something else, which is not very often. The patient middle-aged patient between 30 and 50-year-old would be more likely looking at peptic ulcer disease, tumor, or angiectasia. Some people in this group, or patients in this group, would have non-steroidal and anti-inflammatory drugs related problems. And patient over 50 years of age would be angiectasia or tumor. So the upper GI lesions most commonly we see or miss in the endoscopy. I'm talking about we see because we are a tertiary referral center. In our center, where the DGH people has investigated patients, when they come to our units, most of the time we do the endoscopy as a repeat procedure, and we find abnormality in that. And even if we do the other investigations like capsule endoscopy or balloon enteroscopy, we find quite a lot of pathology in the upper GI tract. And that would be Cameron's ulcer, peptic ulcer, Dulaffer lesion, GAVE, gastritis, fundic, varices, and celiac disease. So we have talked about this. So we go to the next one. Can you see that now? So I did put some quiz, but it's a learning process. So if somebody comes to your unit and you do an endoscopy after a complaint of GI bleed, say for example, hematemesis or melena, there is some studies has shown as high as 75% of bleeding source we as endoscopists can miss, because the endoscopy is done very quickly, whether there are a lot of bloods in the stomach or duodenum, whether there are bleeding that has stopped. So any idea where those are the site where we miss the lesions from? So I put this up here, but the interactive bits is not working. Can you see the slide? Yeah? Number 1 is the duodenal bulb. Number 2, prepyloric area. Can you see that?
Yes.
Yeah. The gastric body along the lesser curve, gastric body along the greater curve, and fundus. The study has shown that most of the lesion missed is actually in the gastric fundus. So this is why when you do the endoscopy, the J maneuver is very important, and you should always look in the upper part of the stomach. So then we come to the causes of obscure GI bleeding. So the majority of cases, this is vascular lesion. And in our society, in UK setting, and I'm sure in United States as well, it will be like elderly patients most of the time. So most of the cases are vascular, Angiectasia, Dulaffer lesion, gastric antral vascular ectasia, portal hypertensive gastropathy, esophageal gastric small bowel, or in rare cases, colonic varices, colonic hemorrhoids, and radiation enteritis. I must say that the hemorrhoidal bleed rarely leads to anemia or any severe sort of disease, because the bleeding is small and patients seems to get or seek help, and unless it is very big hemorrhoidal bleed, they are actually self-limiting and does not cause any problem. Radiation enteritis is one of the things. There are neovascularization, and that can bleed in the large intestine or also in the small intestine. So then comes to inflammatory conditions. The mainly that happens in the upper GI tract is peptic ulcer disease, esophagitis, and ulcers or erosions within the hiatus hernia. That's called Cameron ulcers or erosions. Inflammatory bowel disease that affects mostly in the small bowel with Crohn's disease. The ulcerative colitis affecting the colon can also cause anemia, but it's more often Crohn's disease. Bleeding from Meckel's diverticulum is also related to inflammation, because in the Meckel's diverticulum, most of the cells lining is ectopic, heterotopic gastric lining, and that causes acid secretion and cause ulceration and inflammation. Then, as I mentioned before, non-steroidal anti-inflammatory medication-related inflammation that can cause gastropathy, enteropathy, and colopathy. Next is neoplastic condition. Fortunately, the small bowel tumors are very rare, and bleeding, obscure GI bleeding, can be from small bowel in vascular lesions. But neoplastic condition is in Europe, it's about 3 to 5 per 100,000 cases. So I'm sure in Bangladesh probably would be low as well. So the neoplastic condition, the common thing that we find is adenocarcinoma in our country. In UK, I mean, the gastrointestinal stromal tumor or GIST tumor most of the time are benign and diagnosed pretty early. They are in the they can happen or occur in esophagus, stomach, or in small bowel. Then there are carcinoid is part of them, lymphoma, which is more common in patients with celiac disease. There are some other tumors that comes from other systems, especially like ampullary tumor. Although it can happen in the intestinal columnar cells, it can also come from biliary tree epithelium. Then there are, on rare cases, we see metastatic tumor in the small bowel or in the GI tract. Most common of them is the malignant melanoma. There are some causes that is not within the GI tract, but the bleeding comes in the GI tract. So those causes are hemophilia. I had a case to demonstrate that. I'm not sure whether it will work at the end. Then there is Haemosuccus pancreaticus, where there is hemorrhagic pancreatitis or pancreatic tumor that can cause bleeding through the pancreatic duct, and ampulla vata comes into the duodenum. Then aortoenteric fistula, that tends to occur mostly in the second part of the duodenum, which is close proximity to the aorta. Then there are some rare conditions, which are, some of them are vascular, some of them are different reason because of connective tissue disease. So commonest of them would be the hereditary hemorrhagic telangiectasias, then blue rubber bleb nevus syndrome. There is von Willebrand's disease and pseudoxanthoma elasticus and amyloidosis. They tend to occur mostly in the amyloidosis tend to occur in the patients with Crohn's or colitis, ulcerative colitis. So those are due to chronic inflammatory conditions. This is just a demonstration of Haemosuccus pancreaticus, where bleeding is coming from the ampulla. And on the CT scan, you can see the extravasous blood coming from the pancreas into the duodenum. So this is the slide to show the causes again, the same thing. The small bowel and upper GI endoscopy, where we tend to find no causes in the upper GI endoscopy. When we do capsule endoscopy or balloon enteroscopy, the common causes are angiodysplasia or angiectasia, small bowel malignancy or Meckel's, and small bowel polyps. I'll show some pictures of those. The colonoscopy, as I mentioned, shows some identifiable causes. In most of the cases, the problem is diverticular disease, and there are local anorectal disease and angiectasia. Malignancies are rarely missed, but at times it does show. As I mentioned before, even after bowel preparation, about 3 to 5% of colonic lesions are missed at colonoscopy. So we go to the investigation pathway. The rule for the investigation is that we repeat the endoscopies. So if the patient comes to our hospital, what we do is we do the upper GI endoscopy and colonoscopy. The reason we do it, as I mentioned before, in upper GI endoscopy, we can miss 35 and 75% of cases in acute GI bleed. And in normal times, there are 20% of cases pathologies are missed in the upper GI tract. It can be between 16 to 25%. There are high miss rate in early endoscopy, as I mentioned. There are highly technical and expensive tests after the endoscopy, so it is not available in every places in the district general hospitals, even in UK, apart from CT imaging and barium studies, which the barium studies are gradually being phased out and being replaced by MRI examination. And then the mainstay of investigations for small bowel bleeding is the capsule endoscopy and balloon enteroscopy, and those take time for people to train and also people to have special interest in developing that service. It is quite expensive and does take a lot of time to complete this study. So it's difficult in private practice setting. The other problem we find that the patients are very elderly and frail, so all the investigations that are necessary we sometimes fail to do. Sometimes the people who have recurrent bleeding, we just support them with recurrent blood transfusion and iron infusion. Don't necessarily investigate them as because of their frailty. And again, the investigation pathway will depend on patient's presentation. If the patient comes with an overt bleeding symptoms like hematemesis or melena, they will take one path. If there is an occult bleeding leading to iron deficiency anemia, that will be a different path. So I'll show you those now. So the occult bleeding symptoms, the patient will have bidirectional endoscopies, so upper GI endoscopy and colonoscopy. The overt bleeding, not occult. So the overt bleeding. So they will come to hospital, after resuscitation, will have endoscopies. If we don't identify any pathology or bleeding point that we can treat, but the patient continues to, then, sorry, is there a problem? Sorry, is there a problem? Can you hear me?
So I think you can continue.
Okay. So if after resuscitation and endoscopy, if they are negative, we straightway go to CT angiogram. So CT angiography. And if that identifies the problem, our radiologist usually put a coil in there, or due to their procedure, they actually seal the bleeding vessel or feeding vessel. So that if that fails, or if that is not possible, because the CT angiography will detect bleeding to a certain amount, then the patient will go for laparotomy with or without intraoperative enteroscopy or endoscopy. If the patient comes with a occult bleeding route, that is, they don't have any symptoms but comes in hospital with severe anemia, repeated hospital admission, repeated transfusion, then usually if it happens beyond 6 months, we repeat endoscopy, upper GI endoscopy and colonoscopy. And then we go to video capsule endoscopy. If that identifies a problem, bleeding in the small intestine, we then go and perform balloon enteroscopy. In the past, people used to do push enteroscopy, but the success rate is low, and that has been phased out. In UK, we don't do any push enteroscopy nowadays. It's either a single balloon enteroscopy or double balloon enteroscopy. Then, if that fails to identify any cause, the next test we tend to do is red blood cell scan, where the red blood cell is the bleeding patient's blood was taken out, and the red cell is actually labeled with technetium sulfur colloid solution and then reinfused in the patient's body, and they are scanned again, and that detects where the bleeding is occurring. It's very infrequently used and only limited to certain cases. The identifiable cause in the red cell scan is then have to have further follow-up, either radiological interventional angiography and target that area, or need to have a further endoscopy. The other consideration that people sometimes do that is a barium Milan follow-through to identify any overt lesion that may be small bowel tumor or a stricture that can show in the barium. In our setting, we don't do it anymore. It's phased out now. We do MR enterography or CT enteroclysis. So this is the diagram showing that if there is overt presentation, we resuscitate the patient. If they're unstable, then repeat endoscopy, CT angiogram, and laparotomy or intraoperative endoscopy. If the patient is stable, then repeat endoscopy. And if they remain stable, we do inpatient capsule endoscopy and then enteroscopy. If we fail to find anything, then we consider doing a repeat investigations after discharge from the hospital if it happens again. So our Swansea experience, we have been doing capsule endoscopies since 2010. And we carried out an audit between 2010 and 2014. We found that these cases, 80% were due to iron deficiency anemia, and most of them are elderly patients, and about 20% or near about were due to diagnosis or reason or referral was for Crohn's disease or colitis, suspected Crohn's disease in the small bowel. So the 75% has positive finding, and most common finding was angiectasia in 36% of the cases. We found 6 cases of a small bowel tumor, 4 were adenocarcinomas and 2 were lymphomas. Actively bleeding angiectasias found in cases were treated with balloon enteroscopy and APC. So I was going to talk about a couple of cases. So this is a case of 85-year-old lady came to A&E with 2 episodes of hematemesis and 1 episode of melena, and had a further episode of melena while she was in A&E. She had been treated with iron infusions and blood transfusion from time to time through her GP and to the district general hospital, where they had these daycare facilities when patient goes to hospital, takes had blood transfusion and discharged home on the same day. So she had in the hospitals endoscopy and colonoscopy in the past, and no identifiable cause was found. So when she came to our A&E, she got admitted, and we did an endoscopy on the same day and had a deep duodenal ulcer in the second part, which did not look typical peptic ulcer type lesion. It was quite far down in the second part. So this raised a concern to the endoscopist, and you could see on the picture on the right side, there was a dark area which indicated possibly something is not right. And you could see this irregular sort of shape in here, whitish material. So no therapy was given, no injection or APC, because there was no blood pouring out from there. So the patient was sent straight to CT scan. And on the CT scan, this was found. I don't know whether you can appreciate there is a large, can you see it? Large aortic aneurysm. And that's actually very close to the duodenum. So the next slide. So the patient actually then was referred to the vascular surgeon, had surgery, and was saved. In the case to the 75-year-old man with recurrent episodes of melena over 6 years after a laparoscopic cholecystectomy. She was investigated with OGD, colonoscopy, capsule endoscopy, and no identifiable cause was found, and was treated intermittently with blood transfusion and iron infusion. During the recent admission, she had persistently low hemoglobin, and again, both of them, the endoscopy and colonoscopy was negative. So she had a CT scan. And this was the CT scan. And I'm not sure if you could appreciate there is a problem, that abnormal area in there, where this is the liver. And I wouldn't understand this, but our radiologist said that that is an aneurysm in the cystic artery. So during the cholecystectomy, there was an injury in the cystic artery or whatever. I think it's just the area close to the cholecystectomy site. And then the patient went to have selective angiography, and you could see the aneurysm in here. And the radiologist put coil in there, and that actually is sealed. So case 3, again, there are recurrent iron deficiency anemia. Investigation does not find anything. So this patient came to our hospital, and because the endoscopy was done within 6 months, we did not repeat the endoscopy. We went to capsule endoscopy, and this is the problem. I can't show you this video, but I will try and go to the end and show you some videos of the capsule endoscopy. So this was the picture shown in the small bowel, and this was also in the capsule endoscopy. So this is the old talk. I think we'll skip this. This is the small bowel follow through. I just put it up to show that it is not very useful because the diagnostic yield is very low in case of bleeding. And CT, again, the diagnostic yield is about 10 to 21%, where capsule endoscopy has diagnostic yield between 74 to 85%. In older cases, in earlier time, when they started doing capsule endoscopy, the yield was between 56 to 74%, but this now recent studies with the advancement of technology, it has actually improved the diagnostic yield and is supported with the enteroscopy. So the bleeding lower GI tract is mostly from the colonic angiectasia rather than any serious pathologies. And the miss rate is very low, not high as upper GI endoscopy. It's between 3 and 5%, as I said. So I had some capsule endoscopy video to show, but unfortunately I can't show it. This is an interesting case. A 48-year-old lady presented with severe anemia. So this was the third admission. Blood test confirmed iron deficiency anemia. Coeliac screening test was negative. The patient had surgery in the past in a district general hospital for appendicectomy, and also found to have lesion in the terminal ileum at the same time, so had a limited ileal resection, and then continued to have anemia and intermittent abdominal pain. And the patient had a capsule endoscopy that showed some ulcers. And the other thing I couldn't show you is the video, but I can show you this was the capsule endoscopy finding. I'm not sure if anyone could guess what it was. This is actually a pack of surgical gauze left in the small bowel lumen. We couldn't figure out how that happened. The capsule was retained, and the patient was referred to the surgeons, had surgery, and it was distal to this gauze pack. There was a stricture at the operation site, and that was the reason for the patient's pain. And there was some ulceration at the site, and that was causing bleeding intermittently. So the red cell scan, briefly talk about red cell scan, is useful for only for overt bleeding, where the other investigation failed to identify the cause. And the bleeding, it can be very sensitive and can diagnose bleeding of 0.1 mil to 0.4 mil per minute. And most useful case is useful in lower GI mixed lesions. So in other words, when we don't find anything in the upper GI endoscopy and colonoscopy, if we do a red cell scan, we find that the test is positive, but the positive tests are mostly in the lower GI tract, the 45% of cases. Up to 20% has got a false positive, and about 20 to 25% false negative. The false positivity, they say, is between 12 and 18%. So the other problem this investigation has is that it does not localize the bleeding site if there is blood pooling in the intestine or colon. And usually this will need a follow-up angiogram or CT angiogram. So that's why it is less frequently done. So this is about Meckel's diverticulum, that it's the remnant of vitelline duct between 50 and 75 centimeter proximal to the ileocecal valve. It is present up to 3% of the population, and in 50 to 85% of cases, it is lined by gastric mucosal cell, as I mentioned before. If it bleeds, usually overt bleeding, and there is large amount of blood, and people can have fresh rectal bleeding with it. Usually it's jelly-like blood, but it can also cause melena. Diagnosis is confirmed by Meckel's scan after blocking the treatment with H2 receptor antagonist or PPI. This is technician level scan, and treatment is usually surgical. Diagnosis sometimes can be obtained by barium's follow-through studies, MRI, or CT enteroclysis, or even at balloon enteroscopy or capsule endoscopy. So that's the end of the talk. Now, if you would like to ask me any question, I'm happy to answer. I'll try to show you the videos if I can. I'm not sure if it will run. I had some other cases, but I'm not sure if I can show you that. Can you see my screen?
Yes, sir.
Okay. This is two cases we had dealt with, and one of them I have mentioned in the CT scan. And one of them, and this is how is the other one. me see if I can show you the video. If I can show you the video. Can't share it. Sorry about that. No. Can you see my screen? No, it does not work. I'm awfully sorry about that. Can you see it? No. No. Okay. I think I will leave it here. If I can show you some other cases that we have found in our unit in the endoscopy, during the endoscopy. So this is the vascular lesions.
Sir, we cannot see the slide.
Can you see the slide?
No, sir. We are only seeing obscure GI link.
Okay. So I'll stop this one and move to the other slide. Can you? Oh, this is the same problem has occurred again now. I'm sorry about this. It is open here. Can you see it now?
No, sir. The screen is not sharing.
Screen share.
Hello, নজরুল ভাই আছেন?
Can you see it now?
Yeah, we can see it now.
Okay. Okay. So I'll show you some pictures. So the vascular lesions, can you see that now? So this is the angiectasia. That's the angiectasia on the APC, applying APC and treatment with the enteroscope. That's the face. This is gastric enteral vascular ectasia. So you can see the bleeding, sort of dilated blood vessel all over. This is portal hypertensive gastropathy. This is recurrent bleeding from pancreatic transplant. There you can see the blood coming from that. This is small bowel varix. This is the case of chronic bleeding from small bowel after surgery. And you can see a vascular clip with ulceration there, inflammatory lesion. So this is NSAIDs-induced ulceration. In the small bowel, it causes circular ulceration and usually a circular narrow stricture. This is superficial ulcer with NSAIDs. Then this is the large ileal ulcer. This is again another picture of that. This is ulcerated irregular mucosa. There is a tumor in the small bowel caused capsule retention. There's a polyp. This is a young person. We found a polyp when we were investigating him for Crohn's disease, an incidental finding. This is a small bowel cancer. And this is the picture of celiac disease. Unfortunately, I couldn't show you the video. I had a video picture of celiac disease that led to small bowel lymphoma in the ileum. I had a case and I had the video clips. Unfortunately, I couldn't show you today. This is villous edema that happens with small bowel Crohn's disease and short gut. And this is lymphangiectasia we find in the investigation with the capsule in the small bowel for obscure GI bleeding. This is a polyp, small polyp. That's a flat polyp. That is the polyp. This is worms in the bowel, in the small intestine. We don't see it here that often, but I had a patient referred to me from another district general hospital for capsule endoscopy. He was a what you call it in this country, there is every people go fishing, they would have to have a fishing license, rod license. And he was one of the wardens and that controlling the fishing in the river. And he was having recurrent blood transfusion and he came and had a capsule endoscopy. And that was, to my surprise, he had Ascaris lumbricoid in his small bowel, in the duodenum. And I had those pictures. Unfortunately, I couldn't show you the video clip of that. And after treatment, his transfusion requirement actually stopped and he didn't have any more blood transfusion. So you can see the colonic abnormalities. This is recurrent use or repeated use of laxatives leading to melanosis coli. These are some pictures with the capsule endoscopy. So I think I will stop it here. The investigation with the capsules, sometimes we have retained capsules when we do the investigations for obscure GI bleeding. That's the demonstration of capsule stuck in the small bowel. You can see the capsule there. So that's, I think that is the end of my talk. Unfortunately, I'm very sorry and apologize that I couldn't actually demonstrate some of the thing I have actually put in and 6 of 7 demonstration of video clips. But this is the end of the talk. So the main message is that when there is recurrent bleeding, patient comes in hospital, please do not forget to have a relook using the upper GI endoscope and colonoscopy. If that fails to show any pathology, then the next investigation would be CT angiogram. if there is active bleeding. If there is no active bleeding, consider capsule endoscopy or MRI enterography if you don't have capsule service. And if those identifies any problem that needs dealing with, the step would be balloon enteroscopy or deep endoscopy. If that fails, then of course you'll have to refer the patient for surgery. And that's the end of my talk. Any questions?
Sir, we want to see the video, but it's not been able.
I'm awfully sorry. What I'll do is, if I can, I've got those clips. I'll send it to Dr. Atiquzzahman, and he
Yes,
can
sir.
share it with you.
Sir, can I get it through email?
Yeah, sure.
That will be fine, sir. So will I contact you, Dr. Atiquzzahman, or will I contact through to you?
Yeah. I think I can give you my email address. I'll give it to Dr. Atiquzzahman, and he can send it to you.
Thank you, sir.
Okay. Any questions?
Actually, in our country, we're not able to do these investigations, especially capsule endoscopy.
It has become more or less standard practice in Western countries, especially where there is national. I don't know. In UK, it's late coming in because it's expensive investigations, but in Europe and in America, it has been there for quite some time, and they have got a lot more data than us. The balloon enteroscopy is also more frequently used in America and Europe than in UK, but it is started quite recently that most of the university level hospitals has got it now. In Wales, we have got 2 centers. One is in Swansea, another one is in Cardiff, but we tend to do more. In terms of capsule endoscopy in Wales, we have got 4 centers serving about 3.5 million people. But it's more in England. It's more centers have got them in terms of population.
Okay, sir.
The burden for you to have capsule is, number one, is the cost, because in UK, in the NHS, it costs £750. And if you have to have it privately, it would cost you more than £1,000, between 1,200 to 1,400 pounds. So it's pretty expensive investigations. And the reading time is, on an average, it's half an hour to 40 minutes reporting time. So for you to use it in the private sector, where the medicine is more often available in private sector, it wouldn't be, how do I put it? It wouldn't be economical for you to do this service, because in half an hour you probably would see a lot more patients and than actual doing a capsule. But I think this service needs to develop, because a lot of small bowel pathologies in developed countries are emerging, and especially the Crohn's disease cases are coming in countries like Bangladesh. There are more prevalent. In the past, it was not that case. Yeah.
Sir, Mr. Atik sir, mute kora.
Capsule endoscopy is nowadays is very essential. When I was doing my residency in New York, in Long Island College Hospital, which was a part of Beth Israel, right on that time, Blair Lewis, he started working with this company called Given, which is now Medtronic, on capsule endoscopy. The capsule endoscopy is very interesting. The Israeli intelligence services used to use for their intelligent purposes, and then they come up with the idea, why not to use this capsule to find out the occult GI bleeding? So right now, the cost of capsule endoscopy in India is initially it was at 1 lakh rupee, but now it's 35,000 Indian rupee. So pretty much in Bangladesh, it should be 35,000 taka to 40,000 taka. The cost of a double balloon enteroscope, if you do think about antegrade and retrograde, probably it will be the very similar cost if we do it together. So I think, one of the reasons why we wanted to incorporate is to find out if we can develop that in Bangladesh. Inshallah, very soon we're going to talk to them, but it is a lot of private hospitals in Bangladesh. They're reaching us if they can have it, if we can find a way to train them, which is a good opportunity might come. But we do have some distinguished faculty from Bangladesh here also, and we also go to Bangladesh and train. So that is something which is, I think, will happen very soon.
The capsule, there is a new capsule coming, what they call is the Crohn's capsule, so which can be pan endoscopy, like from esophagus to rectum. So the capsule has got two ends, so they has got a forward vision and a rear vision sort of thing, and the two ends has got camera. So it's like combining the colon capsule and small bowel capsule. So you can do a pan endoscopy using Crohn's capsule, they call it. So it is possible to do a single test when you can examine the whole of the GI tract. The preparation is the problem. Our patient pool is mainly elderly, and they find it very difficult for the preparation. And one thing we have got in our society in UK is the people fasting is very difficult for them. So it is something that will come in future for elderly and frail. There will be more and more these type of investigations, and when the technologies become easier to afford, it will be for people to use. I'm sure it will come in future. Anyone has any question? About any GI bleeding without I was trying to find out the incidences of GI bleed in Bangladesh. I don't know, any idea how often does it happen? I know in UK it is between 15 and 25 per 100,000 population. We have got in America, I think it's about 300,000 admissions with GI bleed happens every year. And they put it as 125 per 100,000 population. In Scotland, in UK, in Scotland has highest incidences of GI bleed. And their hospital admission is between 10 and 12% of acute admissions is related to GI bleeding in Scotland. So I don't know whether any figure that is available in Bangladesh. Shall we end it today?
Yeah, so, if we have no other question, we can end it today. And I'll be in touch with Dr. Mesbah, and, you all can also contact Dr. Sabrina, who's our coordinator with Eminence, and we'll able to send you what Dr. Mesbah promised to send.
Yeah, sure. I'll send you those video clips in a window media play format so that people can actually see it. I don't know, I'll have to take it to our IT department to change it, because I had a trial run on the within the presentation, leaving the presentation, and we can go in and play it, and that worked, but for some reason I couldn't share it today.
So actually, we'd like to have a class on colon cancer, because it's now prevalent in Bangladesh a lot more, especially from where yes, sir?
We do have a colon cancer lecture, in fact, 8 weeks ago, colon cancer and screening, but yeah, no problem. We are going to record it in our next cycle. So very soon, and this time we're gonna also give you the lectures for the whole next 3 months. So you can certainly look at it and you can attend. So certainly we can do that. And in next lecture, whoever will be giving colon cancer screening, it was Dr. Urmi from Dhaka Medical College, but she's practicing in Ohio, University of Ohio. So she will come, and hopefully this time also will bring a colorectal surgeon, and probably will incorporate oncology also the same lecture. So we'll try to make it a little more exciting for you all.
Thank you very much, sir.
So once again, our apology, especially I have to take this credit for that we couldn't able to incorporate some exciting digital pictures and films this time in the slides, but hopefully next time we'll try our best to incorporate that and be careful about it.
I think it is one of it's for Dr. Atiquzzafar is that it would have been better if I actually sent you these things beforehand.
Yes, I think that's what we're going to do. That will work well. So we can have put it together well, and then we can do a test run before we present it. Yes, I think that's a very good advice. Our coordinator, we can put it together and make sure that it's working well. So it will reduce a lot of problem like this in future. Thank you.
Okay.
So once again, thank you all, and we really wanted to thank Dr. Mesbah for this. Thank you.
Okay, you're welcome. Thank you.
And we are looking forward for some more exciting event from Dr. Mesbah in future, inshallah.
Thank you. Thank you.
Thanks.
Okay.